All right, so my name is Jenna Liebersfeld. I'm a fourth year in the medical clinical psychology program, and I'm going to talk to you guys about my thesis project, the effectiveness of a robot social skills therapy for children with an autism spectrum disorder. So first, just introduce myself. So like I said, I'm a fourth year graduate student. My clinical and research focus is in autism. So I do both clinical work with this population and research. And these are my research mentors. Dr. Hopkins is my chair. She couldn't be here today. And Dr. Biasini, Dr. Cook, and Dr. O'Kelly on the committee. So just briefly, I'm going to run through this today, and this is supposed to be a quick presentation, but I'll give you a brief intro on the idea of why we made the robot in the first place, talk a little bit about the design of the robot, and then go through my objectives, methods, results, and discussion. And then we're going to hammer home with the limitations and the future directions of this project, acknowledgements, and then leave some time for questions at the end. So just a brief background on autism spectrum disorder. So according to the DSM-5, that's basically the psych bible of all our diagnoses, it's a neurodevelopmental disability that has two core deficits, so either in social communication and restricted and repetitive patterns of behavior. And it's pretty prevalent, so currently 1 in 68 children is the estimate in the United States, and the gender ratio is about 4.5 males to every 1 female, so much more prevalent in males than females. And about 23% have borderline IQ, and then 31% have an intellectual disability with an IQ less than 70. So that's basically 50% of kids with autism have below average IQ. So just to talk a little bit about the social deficits, this can be in things like emotion identification, recognition, and as we know, you need social skills in order to be productive in our social world, just based on interactions with other people. You need to be able to know how to do that in order to be successful. And what we've seen is it actually doesn't improve just over time without intervention. So as the social world becomes more complicated, you get into adolescence and adulthood, the social expectations are a lot higher than they were when you were just a child. So we need to have interventions for these kids to help them with their social deficits. And that's going to be the focus of this presentation and not as much on the restricted and repetitive patterns of behavior. So the implications of social skills, higher risk of rejection, social isolation, and then the long-term outcomes can be varied. So for people who have higher IQ and better social skills, they're more likely to live independently, have better quality of life, and then poor IQ and poor social skills can lead to lower quality of life down the line. So there's a lot of social skills interventions that have already been created to help kids with autism. There's things like individual therapy, applied behavior analysis, which is kind of like sitting at a table in a one-on-one session learning direct skills, and that can be extremely time-consuming. Peer and family training, so that's where you take a friend or you take a family member, you teach them the skills that they can use to interact better with their child or their friend. But unfortunately with these, a lot of times they don't generalize, which means that maybe they can do their social skills in the clinic, but then if they don't bring it to their school or interactions with other peers. And with family training, sometimes you're not sure, did the kid with autism actually learn the skills, or did the parent just get better at interacting with their kid? So that's where technology-based interventions come in. So human interactions can actually cause a lot of anxiety for these kids with autism, and they have an inherent interest in technology. So typical, you see kids just like glued to their iPads and their phones these days. And so we're going to sort of try and capitalize on that with technology-based interventions. So right here, this is a program in 2011, my research mentor, Dr. Hopkins, for her dissertation project, used this program, which is a computer program, to teach kids with autism social skills. And so what they actually found is they had improved facial recognition, emotion recognition, and then their social interactions on the playground actually improved for the kids that did this intervention, as opposed to just another computer game. But we found that the below average IQ kids were less successful than those who had average or above average IQ cognitive ability. So that's where social robots kind of comes in. So obviously it was still a predictable and reliable environment, technology-based, but we thought that maybe if it took place in a 3D space where you're actually interacting with another interaction partner, that might be more effective than just a 2D screen, like on a computer screen or on a tablet. We thought it would increase engagement and attention, and then there have been other studies that have used social robots to teach kids with autism skills, and so it's really varied in the literature what we found, but overall we see that it improves initiation, turn taking, all of these sorts of things, and you can see like there's a ton of research down there. So these social robots have been very varied in what they do, what they look like. So they go all the way from the non-humanoid, what you would think of as a typical robot like this with metal, all the way up to more human-like on the top left, the more animal or the human-like robots, and then the animalistic ones and the mascot ones as well. So this is sort of a continuum of what could robots look like. So here's our robot, the robot Sam. So children prefer interacting with animals over humans. That's just something that's been found in the research literature. So we wanted to make sure that we had an animal-like robot. Some of the other ones that you saw, the ones that look more like humans, can kind of be creepy looking. And the metal ones, kids like interacting with them, but we want to teach them social skills. That's not as much as similar to a human interaction. So we thought maybe if we use a monkey, sort of has similar human features, but it's still an animal, that it would be the most likely to generalize for these kids. So these are the 6 facial expressions that the robot can make. So these are in the literature, those core 6 basic emotions: happy, sad, angry, fear, surprise, and disgust. And so when the kids interact with the robot, basically the robot sits on the table and then there's a tablet. Different things show up on the tablet. The robot talks to the child, and then the child responds by pressing on the tablet. So like I said, a lot of these kids, they don't have high IQs, their verbal ability is poor, so they actually don't have to talk in order to be able to participate in this intervention. They can just press on the tablet, and they understand interacting with tablets very well. So I have a video here that I want to show you just briefly. This is about a minute, and just a little introduction into what the robot does. Okay, so those are basically the 2 things. Either you get it right or you get it wrong, and that's how the robot interacts with the child. So just a little bit about the intervention is basically it's 8 weeks long, 1 time per week. Each session is about 15 to 25 minutes. There's 5 different games that they play, and it kind of goes from easy to hard, and it gets more and more complicated and have to do with, sometimes there's vignettes that he'll say, you know, I woke up in the middle of the summer and I looked outside and it was snowing. I was feeling surprised. And he makes a surprised face, and the kid has to choose on the tablet what's the matching facial expression. Goes all the way up to eventually he doesn't make the face at all, and he says, how do you think I'm feeling? And then the child has to choose on the tablet how he thinks the monkey's feeling. So I'm just going to skip through the exact details about the robot, but I'm happy to talk to you more about that if you have questions. So previous research with this robot in particular showed that it was the kids were engaged and they enjoyed participating in the intervention. This was 5 to 12-year-olds with autism and average or above average IQ. And they showed that the kids will look at the robot face more than the human face. But some limitations with this project was that there was a ceiling effect, meaning that the kids did really well on the emotion measures, probably because they already had pretty good IQ. These are basic tasks with basic emotions that kids can learn pretty easily. And also the control group was a weightless control, so unknown if it was just interacting with the robot or maybe there was a placebo effect. The parents knew that their kids were in what group the kids were in. So basically for my project, I wanted to make a control interaction that the kids interacted with the robot still, but they didn't know what group they were in. So we made kind of like a dance, emotion-free game that's really similar, where the kid picks a dance move from the tablet and the robot just does the dance move. But there's no words and he doesn't make any facial expressions, so we were hoping it was going to be emotion-free. All right, so basically I wanted to look at this effectiveness in kids of all IQ levels, and we also wanted to look at what parents thought, which they did not measure in previous study. So I wanted to look at enjoyment. I wanted to look at improvements in emotion recognition, which is based on accuracy of the task that they actually learned on the tablet. I wanted to look at generalized social emotional skills based on parent report, pre and post, and also a facial recognition measure where I think I have a picture of that later. But basically, the child will pick which face they have seen before. So there's a face on the top, there's an array of 6 faces on the bottom, and they have to choose the match. So that's basically facial recognition. So one issue was that I needed to have 34 participants to have enough power to run my stats, but we had a lot of problems recruiting. So we thought only including 16 participants would actually be still contribute to the literature, because most of these studies are only case studies or have like 3 or 4 participants. We ended up getting 20, which I thought was pretty good, but not quite 34, so we did have low power throughout. So recruited people just through all of the Autism Society organizations that are available in the area, and the inclusion criteria was school-age children with an autism diagnosis, no vision or hearing problems, and then we did initial eligibility over the phone. And so just briefly, we had 20 people who participated. One child who initially participated had to withdraw because he was super anxious interacting with the robot. He just didn't even want to come back. So it ended up being 5 to 14-year-olds, 19 males, 1 female, and 16 were white, 4 were black or African American. And in general, the parents were well educated, upper middle class. There was no difference between groups on any of these characteristics. So like I said, first we confirmed their eligibility. They had their first session. Then we assigned them to groups, control or intervention group. In the intervention group, they got the intervention that we've been talking about. In the control group, they got the dance intervention, or they just played dance games with the robot. And then we did the follow-up session where we did some of the same tests that we did at the first session to see if they have improved. So I'm going to skip through this, but basically we used the measures for autism diagnosis to confirm their autism diagnosis. We didn't just go by parent report or teacher report based on diagnosis. We measured their IQ using the Kaufman Brief Intelligence Test. We measured their language skills using the Peabody Picture Vocabulary Test. This was the Benton Facial Recognition Test that I was talking about earlier. We used the RBEST, which is basically the accuracy on the tablet. How well did they match the emotions to the tablet? And this has 24 total trials. Basically, there's 12 drawings, 12 photos, and 4 of each of the 6 emotions. That equals 24. All right, here's a big table of characteristics, but basically what you need to know is the intervention group and the control group did not differ from one another. So if you look on the top right, they had high autism characteristics, so these kids definitely had autism moderate to severe. Their verbal IQs were in the borderline deficient range, and their nonverbal IQs were in the low average range. That's a pretty typical split that you'll see in kids with autism, where they have a nonverbal strength and verbal weakness. Overall, their IQs were in the borderline deficient range, and same with their language skills. They were in the borderline deficient range. 18 met qualification for autism, and 2 met qualification for autism spectrum. Okay, so the parents fill out a demographics questionnaire, and they also filled out a rating of their kids' social skills. Then the kids were assigned to their groups. And then the final session, we measured their accuracy again. We measured their facial recognition again using the Benton. We had them fill out an emotion or an enjoyment questionnaire, which is basically 2 questions. How much did you like it, and do you want to come back? Some of the kids were not able to do that because their IQs were too low. They didn't get it. But 17 of them were able to fill that out. And then the parents rated their social skills again and rated how much their kid enjoyed it. There was some missing data. I'm still hopeful that the T2 questionnaires will come back in the mail at some point, but we'll see. All right, so basically I tested the differences between groups, and I tested the change within groups over time for all of my aims. All right, so enjoyment. So basically everyone liked it, no matter what group you were in. So the intervention group liked it, the control group liked it, and the kids and the parents both rated the child's enjoyment as high. So emotion identification accuracy. So the intervention group did not improve more than the control group on the accuracy of the task. So both groups got the test at pre-test and at post-test, and both groups improved within each group over time, but the difference was not significant. So basically the intervention group got 3 more questions. The control group got like 2.5 more questions on average, but that wasn't different between groups, so everybody improved. Same thing with parent report. So parent report of the kids' social skills did not differ between groups, but everybody improved. Lower is better. This is a measure of impairment. So the intervention group improved about 5 points, and the control group improved like 8 points. So over time, that was a significant improvement, but between groups, the difference was not significant. For facial recognition, we did not see an improvement for either group, or there was no difference between groups on that measure. So in summary, basically everybody liked it. The accuracy and the parent ratings did not differ between group, but they improved over time, and the facial recognition did not improve over time. So what does this all mean? So A, the child who discontinued due to anxiety. So obviously we took a lot of precautions to make sure that the kids were not anxious, but some kids need to basically get treatment for their anxiety before they're going to be able to participate in this intervention. 3 children could not attend to the intervention task. That basically means that they were just picking randomly. They could not understand what was asked of them in the task. So really I should have probably screened them out in the beginning. They should not have participated. And something like ABA, less applied behavior analysis, a different kind of intervention first, would be more useful for them as opposed to participating in this kind of intervention. All the other children were able to complete the study, so I think it's feasible with better screening to have the kids participate in this sort of intervention. So enjoyment and motivation. So the good news is that everybody enjoyed participating. And for kids with autism, that's actually huge, because think of a kid wanting to go to therapy. Like, that's pretty cool. And so all of the kids were so excited to tell their kids at school, oh, I get to play with a robot. So it's very motivating, enjoyable for them to participate. So in general, I think that means looking into social robots for kids with autism is still a good thing to do. But as far as this particular task, we did not see a group difference on the accuracy of the emotion identification. Both groups improved over time, probably due to practice effects. They kind of learned the task the first day, and so even the control group, 8 weeks later, they still kind of remember the right answer. So it's a simple task. So probably if I had to do this again, I would use a different emotion measure that neither group saw at pretest to see if anybody improved. So parent-rated social skills. So there wasn't a difference between groups on the parent-rated skills, but both groups improved over time. So either it might be a placebo effect, even though I tried to control for that based on having the parents didn't know what group their child was in. They are putting a lot of time and effort into participating in this intervention, so it's possible that they really hoped their kid was in the intervention group, and so they rated their social skills as improving over time. Another option is that their social skills really did improve over time, but not because of this. Kids are in a ton of different kinds of social skills therapies all the time. I have therapy at school, and I didn't collect that information. So I don't know. I should have put that in my demographics questionnaire. What social skills therapies are your kids getting right now? So facial recognition didn't have significant findings. So the measure that I chose might not have been sensitive enough to pick up on slight differences that the intervention group might have had over the control group. And it might not be validated for use with this population. So I didn't speak on this in this presentation, but basically this was developed for people in the TBI population, traumatic brain injury, and it's been used in a lot of research with kids with autism, but the validity and reliability hasn't really been studied. So limitations in future directions, obviously increased sample size. So my power was really low to find group differences. So I need to have more participants, and also could employ an A-B design next time. So basically have both groups be in the control group and the intervention group, but randomize it to if you have A or B first. And that would basically double the sample size. I have twice as many observations. So the participant characteristics, the parents were well educated and upper middle class. So future research should have a more diverse sample. And there's only 1 female and 19 males. So future research should have a more representative gender ratio of 4.5 males to females in autism. And in general, future studies should definitely still use participants who have below average IQ in autism. So in general, in the literature, a lot of it is just average and above average IQ. They're a lot easier to recruit. They're a lot easier to keep in the study. But in general, 50% of the autism population has low IQ. So future research should definitely include those participants in their sample. And also I'm going to look at which participant characteristics predicted improvement over time. So basically I just pooled everyone together for this, but I haven't looked at age, I haven't looked at autism severity, IQ, and whether or not this predicts improvement over time. So the control group was exposed to the emotional stimuli at the beginning, like I said, so maybe some kids should be in a waitlist control group so they're not exposed to it at baseline. Was the robot dance control group actually emotion-free? Who knows? Maybe for some reason interacting with the robot, even just looking at the facial features, somehow improved their social skills over time. And if I was going to improve the robot in the future, maybe the SAM robot intervention just really isn't where it needs to be right now to have good social skills improvement. So maybe the content needs to be different, maybe the higher frequency, maybe longer sessions, maybe more sessions, who knows? So these are all things that I want to look at in the future. So main takeaways, the robot is enjoyable for children with autism across all levels of cognitive ability. Maybe it improves emotion identification, maybe it improves social skills, but we definitely need more power to look at that. But in general, I think social robot interventions should be continued to be tested for kids with autism. All right, so thank you very much to my entire committee, my chair, other graduate students who helped me, the Social Technology for Autism Research Lab, the STAR Lab, Civitan International Research Center, CCS, Sparks, and all my family and friends who helped me get through my thesis project. All right, so with that, I'll end, and thank you all for listening. Any questions? Yes, sir.
I have a lot.
Okay, hit me with them.
Well, one is not a question, it's more of a comment.
Okay.
You have a small sample size, but you also have a very small population that you're dealing with.
Mm-hmm.
So relative to the population that you're interested in, your sample size is not that small. So I wouldn't keep stressing, oh, we have a small sample size, we have a small sample size. It's not that big of a negative here. If you're studying diabetes and you only get 20 people, you need to work harder. And that being said, if you go back to your slides that had your results on it, you had several results that looked fairly good.
Like from the means?
Yeah, because they're all going the way you would want them to.
Correct, definitely.
And so that would be what I would push when you write this up, is that, yeah, we had a small sample size, but we're using asymptotic statistics. So they're obviously not going to be able to find anything unless there was an enormous difference.
Right.
But everything is tracking the right way. So don't oversell the negative, push the effect sizes, push the fact that you did see an improvement. It wasn't significant, but you did see it, but you're in a small sample size, you're using asymptotic things. Likewise, there's one or two slides more, one more, that one.
This one?
That one. So there's a huge difference in the variance between the intervention group and the control group. Mm-hmm. There's not that much of difference in the mean, but it is going, I think, the right way, right? Because you want it to actually be 0 or positive, right?
You want it to go down over time. You're talking about the means?
Yeah, so the difference.
Can you see this?
So what do you want, a bigger negative number or a bigger positive number?
Negative.
You want a bigger negative number.
Yeah, so the control group actually improved more than the intervention group according to this slide.
But the variance is much different. So yeah, the intervention group on average might not have gotten down where the control group is, but the control group were all over the place. So yes, the control group may have on average moved down, but you're doing it with 20 people, average might not be the right thing to look at anyway. So I would maybe potentially do a test for variance here to show that the intervention group was much more precise in what they were doing. So they were all very similar, and the control group, the people were all over the place. So yes, you might not on average get the same result, but you're going to get a more consistent result.
Yeah,
you know
that's a really
what the
good
child
point.
is going to improve and what it's going to be, as opposed to just being all over the place.
Yeah.
And there are statistical techniques that are much more small sample for that than these large sample ones. Additional to that, there are meta-analytic techniques that are used a lot in these those N=1 studies that you had, the ABA studies, I think is what they're called. There are meta-analytic techniques that treat each kid as its own trial, right? So each child is different.
Right.
And that might be something to consider if you're going to go forward with this, is not do asymptotics, but treat each of your 20 children as their own trial, and then combine it through a meta-analytic approach. That's just one.
Yeah, that's really interesting. I'll definitely look into that.
So, Dustin, sorry, can I ask a follow-up question? So if you expect to have long-term effects, can you do these sort of crossover studies? So
the AB study that you talked about doing later, I don't think you can do that in this population, because you can never cross back from being with the monkey, right? You can never go to the state in which you didn't know the monkey was there.
True.
Right, so it looks like a waitlist control, where you have intervention and control, these people get intervention, these control, and then these cross over, but you don't do anything with these people.
Okay, yeah.
Because they can't go to control ever.
Right, because they should maintain their gains over time, theoretically.
Well, and they can't forget that they knew the monkey.
Right.
I mean, if it was a drug, you could give a washout period and they could go back to what their body was pre-drug. But with educational, behavioral type interventions, it's really difficult to have a washout period. So your waitlist control, I think, is probably a fairly appropriate one here. But otherwise, this is a very excellent study. I just want you.
I appreciate
you were very
that.
negative in your results. You're like, we didn't find anything. But no, you found some very interesting things that might be a factor of your population, not necessarily of your study.
Okay. Yeah, that makes a lot of sense. Thanks a lot.
This is fascinating. So thank you for sharing. Question for you: if you were to refine the sound robot, how would you go about refining that?
The intervention itself?
Yes.
So
that was not your study, but if you take these lessons learned, how would you refine the intervention?
So one thing that I would definitely do is the stimuli that we're using. They're all in black and white, and a lot of the pictures that we're using, the stimuli themselves, I think I would update those. As far as the intervention games themselves, I think I would make them more varied. So right now there's only 5 games. And I would definitely increase the amount of time that the kids interact with the robot. So right now it's only once a week for 15 to 25 minutes. A typical intervention session for kids with autism would be at least an hour a week, but ideally more often. So I would definitely do that. As far as feasibility, whether or not parents would be able to participate in that, I don't know. And then, I mean, down the line, I think it'd be awesome if this could be mass produced and put into like schools and therapy centers. So that one teacher could potentially be teaching multiple kids in a one-on-one setting using the robots. So that's sort of where I see this going, personally. Yeah.
Can you talk a little bit? So it seems like the tests are these line drawings.
That's one of So one of them is line drawings and one of them is faces.
Yeah, and I wonder for the facial, the emotion line drawings. Okay.
Yeah, these. So there's basically 2 stimuli. There's the line drawings. And there's these Ekman and Friesen faces, which are pretty typically used in the emotion identification literature, but they're in black and white. They're pretty old.
Okay, and those correlate pretty well in terms of, if the kid can recognize these, they can recognize the human
This
faces
is
as well.
easier. So because the specific lines are really highlighting which areas of the face that you want to look at, and then those faces correlate really well with the monkey's faces, whereas the human faces are a lot more complicated. So we try to replicate some of the things like the eyebrow lines and the eye folds into the monkey, so his face is a screen, so his eyes can sort of make some of the human features. But the line drawings are definitely easier. So they're not as well correlated, but in general, the emotion identification is correlated over time, but these are easier. Yes.
So you had a wide age range and it was tough to recruit. So
Right.
I get why, but out of curiosity, are there certain characteristics or behaviors that become sort of more baked in as kids get older? Is it easier to modify behavior if they're younger?
I think it's different. So the younger kids are definitely in general more hyperactive and have more negative behaviors, but actually as opposed to chronological age, I'm more interested in mental age because, I had a couple 14-year-olds in the study who they scored in the 40s on their IQ, which is in the severely impaired range. And so their age equivalent is like 4 years old. So I'm actually more interested in that. Their attention was poorer. So for them to just even sit and attend to the task was more difficult. So I think those things improve over time. So I would say like behaviors, hyperactivity, and attention, I think that sort of improves over time, maybe without intervention. But as far as the emotion recognition and identification, I think it gets harder over time to interact with your same age peers as opposed to improving.
No, I guess what I mean though is not necessarily whether they're better at it or where they are sort of at baseline, but just in other studies that are not robotic, that are just looking at intervention.
Yeah.
Are there differences in how they respond to intervention based on age, or does that get better, or does it stay the same over time?
That's a good question. I'm not really sure.
Get them into therapy early.
Yeah, the type of therapy changes. So it will be maybe a play-based therapy for younger kids, and then as they get older, if their language skills are better, it will be more lesson-based. So more a story. You are going to go interact with Johnny on the playground. You know, how are you going to start talking to him? Versus with a younger kid, you might actually go with him to the playground and help him interact with Johnny. So it'd be more hands-on. Is that sort of the question that you're asking?
No, I mean, I understand the strategies would change, but are they equally able to respond to the intervention? Or do you see bigger gains early?
Oh, I think bigger gains early. Oh, you're saying, is it more cemented if they like don't get intervention?
That's what I'm
Definitely bigger gains the earlier, just because of neuroplasticity. I mean, their brains are just more able to take in information and quickly apply it, versus if you wait until they're 10 or 11 even, to start teaching them about social skills, they've had 10 years where they weren't thinking about it.
Right, so that's what I'm wondering, if maybe sort of trying to sample then kids that are younger who might be more receptive to this game and have more plasticity in terms of their response, maybe you would see greater effect sizes.
Yeah, and that's definitely something that I would be interested in. I don't know exactly how many. I mean, the average age was 9. I think the standard deviation was like 2. So there is a pretty wide range. So it's splitting that up and then looking at that is definitely something that I'm interested in. As soon as if the sample size increases a little bit more, that'd be something I would definitely look into.
We have one last question in the interest of time.
My question was actually very similar, just about the age range and whether there are differences in children's ability to respond or understand those emotions across that age range. So it's a pretty similar, but I guess different question. Did you see anything about that in literature, just in their understanding of this?
I think, yeah, basically, I think understanding of basic emotions, especially as basic of these tasks, would improve over time. Theoretically, I do think that would be moderated or mediated by age equivalent, basically. But yes, I would imagine that I would probably see something like that if I looked into the age. All right, thank you very much. Just kidding.
So I'm Sam Baker. I'm a third-year general surgery resident doing 2 years of research through the Quality Scholars Programs and Health Services Research and Quality Improvement, and I'm in Dr. Morris's lab for those 2 years. This presentation is kind of a practice for one that Elise and I have coming up in about a little over a week and a half for the American College of Surgeons. So any feedback you have on graphics, if you can't see something, color, you don't like the way I explain something, or something's not clear, please let me know. I have plenty of time to change it, and I really appreciate any feedback you have. So this, thank you so much for being here to listen to our work. It's patient-reported health literacy scores associated with readmissions following surgery. We have nothing to disclose. While this is a VA study, the data presented here represents the opinions of myself and the co-authors and not that of the federal government or the Veterans Affairs Department. So some background. We embarked on this study to better understand surgical readmissions. They're a difficult problem to tackle. It's hard to define who should and shouldn't be readmitted, which ones are preventable, who's more likely to come back. And there's been several studies using big data to look at this that has given us a lot of insight, but hasn't really helped us answer the question. And furthermore, with patient-reported outcomes on the horizon, is this going to help us, hurt us? Is this going to be the thing that really helps us nail down who's going to come back? We don't know. And then how does health literacy play into that? So for this project, we chose to focus on health literacy and how it was related to readmissions. Our hypothesis was that patients with lower health literacy would have a higher rate of readmission following surgery. So this is an observational, prospectively enrolled, multi-institutional study with 4 VA sites across the country: Birmingham, Palo Alto, Milwaukee, and Boston. Patients who underwent general vascular or thoracic surgery were eligible. They had to have at least a 48-hour hospital stay and be discharged alive. And before they left the hospital, they had a discharge survey with lots of measures, but one of them was health literacy. Patients were then followed for 30 days, and one of 3 things happened. If they got readmitted to one of the original 4 sites, they got an in-person interview to better understand that readmission. Everyone underwent a 30-day chart extraction to look for readmissions to another VA hospital. So whenever you're readmitted through the VA through CPRS, there's communication about that readmission. And then third, everyone got a 30-day follow-up phone call to identify any readmissions that were missed to a VA or to any outside hospital. So that way we could get as much information about readmission as possible. We needed to define health literacy. There are several tools out there to do that, ranging from 3 questions to 25 questions to 52 questions. And we chose a shorter one. We chose the 3 questionnaire, or it's called the Choose score. It's 3 5-item Likert questions. The questions are: how often do you have to have someone help you read material? Do you have problems learning about a medical condition because you have difficulty understanding written information? And how confident are you filling out your medical forms? They range from never to always. For the first 2 questions, never is the better answer, the lower score. And then for the last question, it flips, and always is the better score. For the purposes of this study, we chose scores from 0 to 3 as adequate, and anything over 4 is possibly inadequate. So we were able to enroll 736 patients across the 4 sites. Of those, 722 completed the health literacy information at discharge, about 98%. Surgical specialties are represented there, with 44% coming from general surgery, followed by vascular and then thoracic. The distribution between enrollment sites: one site made up about 50%, the second and third site split those, and then the last site had the smallest enrollment. Part of that was because they joined our study about a year into it. The demographics of our entire cohort are that what you would expect of a VA population. They tend to be older, mostly white, mostly male. But how prevalent is health literacy or low health literacy in the VA? So we look at health literacy at discharge. Out of the 722 patients who underwent the survey, 39.2% had a score of 0. So that means for how often do you need help understanding, they said never. How often do you need help reading written stuff? Never. How confident are you filling out your medical forms? Always. So 39.2% had a score of 0. But 33.2, or a third, 240 patients had a possibly inadequate health score, or score 4 or more. So if we look at our population characteristics stratified by health literacy, looking at adequate health literacy versus inadequate, the distribution of races is pretty similar. There tends to be more white people in the adequate and more African American patients in the possibly inadequate, but it was not statistically significant. The age is, our adequate population tends to be younger at 64 years versus 66. There tends to be more females in adequate versus inadequate, but the female population in the VA is pretty low. And then interestingly, if you were married, you were more likely to have inadequate health literacy. If you were single, you're more likely to have adequate health literacy. And then Charleston Comorbidity Index is a measure of comorbidities or overall health. Our adequate health literacy population tended to be a little bit healthier or have a lower score. Some of the other things we measured at the time of discharge was the CTM-15, which is a care to transitions measure. It measures the quality of discharge. So it looks at several things. Do you have a new amputation? Do you have a new wound? Do you have drains you're going to take care of? Who's going with you? Where are you going? Several questions. And then the mental component score and the physical component score are just what those sound like, looking at your ability to get around, or your history of mental health. So the care transitions measure, there was a difference. It was only 3.3 versus 3.2. We tried to dive into these series of questions to figure out what the difference was between the two. It seems like the only one that really was different between two groups is that possibly inadequate had more people going home with drains, and that maybe what's giving us that number. We're still kind of diving into that to figure out that. And then our physical and mental component score shows that our adequate health literacy group were overall had better mental health and better physical health. So overall rates for readmission and emergency department visits. So within 30 days of discharge, our readmission rate was 16.7% for everybody and 20.5% presented to the ED. So what did this look like if we looked at it based on health literacy? So patients with adequate health literacy had an unclaimed readmission 13.7% versus people with inadequate health literacy, it was 22.5%, and this was statistically significant. For the ED visits, we see a trend towards the same thing. Was not statistically significant, but this study was not powered for ED visits. We were looking at readmissions. I think if we had enough for that, it would show a similar trend. So now we're looking at our model for readmission based on health literacy. Adequate health literacy would be the reference group. In the unadjusted model, the odds ratio of being readmitted is 1.83 if you have inadequate health literacy. Once we adjust for the comorbidity index, the physical component score, the mental health component score, we get an odds ratio of 1.53. On the unadjusted model, there's a very nice linear relationship between the unit increase in your health literacy and your readmission rate. Once we adjust, we kind of lose some of that statistical significance, and our p-value is 0.08, but it still shows a positive trend. So what this is telling you is that patients with possibly inadequate health literacy at the time of discharge are 53% more likely to be readmitted compared to patients with adequate health literacy. So in conclusion, low health literacy is common among VA population. It's a contributor to readmissions following surgery, and we should, in the future, identify these patients so we can develop interventions to educate and empower this vulnerable population prior to discharge. There are some limitations to this study. First, there's several tools to measure health literacy, as I mentioned before, and this is the one we have chosen. It makes it hard to, compare studies, but there's different tools. There's not a whole lot looking at people using multiple tools and their integrated reliability, although Dr. Chu is kind of working on that now. There's also, most notably, no validated or consistent cutoffs between adequate, marginal, and inadequate. People kind of agree on adequate and inadequate for the most part, but there's really no consistency on when you stop that point and where it's marginal versus inadequate. And then obviously it's a VA population, so it comes with it may not be generalizable to populations outside the VA. I'd like to thank these people, the surgery department at UAB, Dr. Morris, and then all of our research teams at the other VA sites and then here at the VA, and I would be happy to take any questions. I got my notes.
We first want to do maybe just questions about the science and then focus to comments about the presentation.
Sure.
We'll do it that way.
Yeah, this is a question.
Yes, ma'am.
So first of all, I guess we'll talk about the slides in a minute, but that was a really nice presentation, and the slides were really clear and simple. I liked that a lot.
Thank you.
So I thought visually it was great. I'm curious, so we listed somewhere sort of the demographics that you considered. I forgot which, like the baseline characteristics. And I'm wondering if you measured anything regarding sociodemographics, like education or wealth or any kind of measures of social
determinants of health.
Just as they're so highly correlated with literacy. And so the conclusion here, because we're not measuring any of that, is that it's health literacy, but I'm wondering if health literacy could be a marker of poverty or something like that. And so, attributing the causation to that specific factor without knowing much about the other factors is kind of a leap. So I'm just wondering if you have that data, if you guys looked at that at all.
We have some of it. We haven't looked at it in relation to health literacy, but overall for our entire cohort, I think we do have education level, mean salary, and a couple of those things. But there are studies that show, especially with at least most, so I will say that health literacy is not studied in the surgical population, but it's pretty regularly studied in like primary care. Mm-hmm. And this 3 questionnaire was validated for that on its own. And actually the how confident are you filling out medical forms by itself was a 1 question health literacy question. So we feel confident using this, but I understand what you're saying, that it may just be a surrogate for that.
This is just a tiny little add-on comment, but I was wondering about this measure. It's just not one I'm familiar with. So I think it would be helpful to put some kind of a reference there and maybe some information about to what extent it has been validated, and be definitely ready to discuss that, because I think that'll, depending on the audience you're presenting to, people.
I think your question's great. Social determinants of health are not as well studied in the veteran population, and I think there are some assumptions that may or may not hold true with the veterans because they, in theory, have access to all the care they need, including all their medicines are paid for, all their supplies are paid for, discharge to nursing home facilities is always covered. So some of the things that social determinants of health may play a role in a non-veteran population may or may not translate to the veteran population, but it's not as well studied.
Oh, my question was, have you seen measures of health literacy that are specific to either surgery or discharge readmission? Just wondering if that exists, and would you consider, I don't know, that kind of approach versus this general approach, if possible?
Can you state that again?
So just thinking about health literacy, there are in some conditions, there are measures that are specific to whether a patient understands instructions for taking medication, specific medication, or the specific procedures that they should go through once, they're discharged, for example. I was just wondering if you considered the possibility of either, creating that kind of thing, like what might, would there be benefits compared to general health literacy?
Yeah, that's a great question. So there is no validated for surgery health literacy form. Like I said, most of the research is done through primary care. We chose this instrument. Dr. Chu is actually doing studies where he's using 3 different survey questions that look at health literacy and looking at the difference between the 3. I think it would be hard to make a surgery specific one just because, some people are going to have new ostomy, some people are going to have new amputations, some people are going to have drains, people are going to have wounds, people are going to go home, some people are going to have nothing.
Right.
And I think that would be really difficult. But it's definitely an intriguing thought, right? And I know that the colorectal department also has an app now that interacts with people and tells them when to take their antibiotic bowel prep prior to surgery and then what they should be doing post-op day 1, all these things. And, maybe if we're able to, tone that down to surgery patient-specific things, and maybe we can also do that with the health literacy form, yeah.
But to further answer your question a little bit, part of our discharge survey, we're only reporting part of it here, but part of it was, do you have new medications? Do you understand how to take those medications? Do you have a new wound? Do you understand how to take care of your wound? And also we collected, have you had all of your discharge teaching from both pharmacy and nursing and the surgery team or not yet?
Okay, so great talk. That was very interesting. I have one question for you. As far as the health literacy survey that you've talked about before, how did you determine the cutoff of 4? Was that something that's already been validated, or how did you determine that for this study?
No, it's not. So, and that's a great question. So there's been one other study that's been published looking at health literacy and surgery. It was through the Vanderbilt group a couple months ago. And they chose a different scale than we did, and they also assessed all of their health literacy on admission and didn't do it prior to discharge. And they found, and it was a retrospective study, and they found no difference at readmissions. But we were looking at, we were looking at the linearity of the association between point increase in the health literacy score in your case of readmission. If you look between 3 and 4, there's not that much difference. It's like a 5% increase. But between 3 and 7, that is a big difference. And we felt that choosing 3 and under was a very conservative number, and that would give us the best chance to find a difference. And so that's what we went with. But that's definitely a limitation of the study.
Given the discharge that you make, which is great, I'm asking you to prepare this stuff. You've already got it, which is fantastic. It would raise the question of why dichotomize? I mean, looking at so when you first get data descriptives and you look at kind of distributions and plot, so you've got a few distributions, so you've got, a 30% sample that has none of the condition. But when the exposure response relationship, I'm interpreting this correctly, you would ask the question of why do you use dichotomy? This to me is really an elegant slide to show your data and show the relationship between health literacy and readmission. I would suggest considering keeping this in the body of your talk in the results section.
The reason it's not is because it's not statistically significant. It's 0.08 p-value. So that bothers some people, so we had it in a to talk about. But I think the thing we struggled with there is that with not dichotomizing it is picking where marginal ends versus inadequate. And we just really struggled on trying to put it into 3 groups and finding where we would draw the line between those two. And so we decided that it was easier for us to interpret and use if we dichotomized it. But I understand what you're saying.
Yeah, no, it seems like you're saying, the field is really in its infancy. I mean, there's just one. I think you have somebody on the call in on the computer. Maybe you can mute your line.
I think you can put it right there.
But Sam, it just seems, just to consider, because it seems like this is a wonderful contribution to the field. I mean, like Fisher would roll over is great, right? I mean, instead of 0.05 being somewhat hard and fast rule, I mean, a P of 0.08 versus 0.03 versus, like, that is such an old figure. And just thinking about, if not in the presentation, I think really in terms of advancing the science in the field. But again, you have to know your audience and know if folks are going to be so bent on 0.05 p-value to say this matters or not. But yeah.
Would it benefit to do like an ROC curve with? Is this a continuous variable? I came in late, sorry, but if you could figure out if there's a threshold where the risk does increase, like you said. You
no, that's a great question.
At 4, where it just kind of the odds ratio jumped, but is there a way to kind of look at that, make a curve, see if you can figure out a sensitivity or a positive predictive value or something that you could maybe narrow into where you can.
It's called a J statistic.
Yeah, exactly. Yeah, or a C statistic or something that you could create that would be interesting to look at and say, well, in the surgeon population, there's let's 75% course of everything. Readmissions, I don't know if there's something that was on your sample stuff.
Okay, great, thank you.
So 2 statistical issues. So what if you can go, so overall, I should start with, overall, I think this was really nice work. And I think you did a really nice job presenting it. So if you go to the slide where you've got the, this slide. Okay, something went wrong with your standard deviation.
Yeah, because they're all, I noticed that, yeah.
Okay. And then the other thing, with your, that supplemental figure that you presented.
Yeah, thank you. I don't have
the,
He's trying to move on.
Trying to
yeah.
I'm not sure how to give arrows over the.
Oh, okay. So Matt,
Well, so I don't know how to mute it, but you can see who's on the line by hitting the little arrows at the bottom of that bar. It'll expand it and show you who's on the line. So who attendees.
Okay.
So it looks like that's
the raw data.
Oh, there you go.
That's not the one.
Yeah, the raw data showing range.
That's what
Thank you so much.
okay, so this doesn't quite match your results that you showed the odds ratio.
Yeah.
This is the adjusted one. Not yet.
Yeah, but the confidence intervals, I mean, that just looks like it's not quite, it doesn't quite line up. So I don't know where where the confidence intervals on those point estimates come from versus this, because they don't seem like they're quite.
Well, I think
What's wrong? What do you
Look how narrow those confidence bounds are versus on the plot versus the confidence bounds for the 1 unit change. The 1 unit change overlap 1. So I'm not sure, I mean, it's possible that, yeah, I'm just not sure. That just doesn't seem consistent. And there could be a good reason why it's not consistent, but
I will have to talk to Dr. Laura Graham about that. I have no idea.
And today is the day we have to leave at 9:20, so I want to leave time, I think if we can follow up after, Sam, like clearly this has been such a great presentation, got great feedback, so follow up after directly. But I want a little bit of time to talk about the content of the slides also, so maybe a few minutes before we close out. We'll talk, yeah.
This is minor, but on the slide, you had a typo, the one that was talking about health literacy, and you had the 3 different panels, and it said Han instead of How, which I thought was
where?
Yeah, so in the middle. So.
Oh, look at that.
Yeah, I thought that was
Dr. Han on my mind.
Yeah, just detail, and then, in terms of presentation, the slide before this, I too, like what you was looking, or actually the slide where you give how you determined your cutoff.
Mm-hmm.
I also was wondering like how, and it sounds like there's not a lot of, you know, but if you could somehow denote that, because the whole talk I was like, oh, I wonder how she,
Okay.
you know, and then if someone else is thinking that, then it's possible that your audience is also
Okay.
kind of distracted by that. I think those were the two like specific points. But it was great. I really enjoyed it. Are you good on your time in terms of how much allotted time you have?
Yeah, I have 8 minutes, and so
Okay.
I think I'm a little under that.
Okay, I felt like you did talk a little fast at times. I'm not a surgeon, so a lot of it wasn't as intuitive to me, but if your audience also is not all surgeons, like the comment about drains, like maybe this is because more patients had drains, like that didn't click for me, so
Okay.
that slide, if you could maybe elaborate a little more, I think it would be helpful.
Okay, thank you.
So Sam, along that slide, I was actually going to suggest considering that to me seemed extraneous. So when I'm, those outcomes, while you might include them in a paper, I was focused on hospital readmission and ED visits. So you had to introduce those measures, and it kind of popped up as you're talking through it. Why is this relevant to this 8-minute, focused talk? So,
Yeah.
even though you have the data, I'm not sure you necessarily need to include those data.
Okay.
I think, your punchline about readmission and ED data is so good that I would hate to detract or distract from it.
I felt like since we were adjusting for physical component score and mental component score, I should include it. But I don't know if that's correct. I mean, I was open to whoever.
Yeah, for you to consider, you can keep it in the backup slide if you decide you want to keep it, or you can mention that you did control for those factors. But again, for me, it was more of a distractor from the main point.
Okay.
The only other kind of stylistic thing, I never like I love finishing with acknowledgments, and that was great. I never like finishing penultimate with limitations.
Okay.
I like to finish with something that is maybe implications, next steps. So it's, just thinking about after your conclusions, which were a summary of your kind of study findings. So here's what I found, summarized with data, with numbers. Here are limitations, and then implications is something to consider, so that you're finishing on a positive frame in terms of, what are the implications of your finding for the field scientifically, as well as, surgically.
Great. Thank you. Yes, sir.
You're going to get a question about the people who died post-discharge, and I did not see that anywhere in the slides of what you did with people who died, or if nobody died. I didn't see that. You will get a question about that.
So if they had an in-hospital mortality, they were not included.
Post-discharge.
So within the 30 days,
yes,
we did have mortalities. I don't remember the rate or what we did with them.
I would just insert somewhere in there that what they were in the number, just so that people, because it looked like you had a completely live cohort at 30 days.
Unfortunately, no.
Yeah.
Okay.
It's not a lot, but we'll look at it.
And that raises for the future things, like if it was a substantial number of competing risks, that means, health literacy.
Well, this screen analysis, if you've got the dates, everything.
Yeah.
We do, because it's all in CPRS and then chart abstracted out.
Very much.
Thank you.
That was fantastic.
Thank you.
So for my presentation, I still have some formatting and other things to go into. So I'm not really focused on time right now. But areas that I'm looking for feedback on, or areas that maybe I should go into more detail or less detail on, maybe different ways to display data, and if there's anything that's unclear as well. So good morning, my name is Lily Stassinger, and I'm happy to present my team's work on the impact of preoperative and postoperative opioid use and surgical readmissions. No disclosures, although items presented here are opinions of my own and authors and not that of Department of Veterans Affairs. So since 1999, the number of opioid-related overdose deaths has quadrupled, and this goes along with the quadrupling in opioid prescriptions written and dispensed. So we've seen it in the news, headlines everywhere you look. And what this has led to is providers to take action and the health community to take action. And this also includes the surgical community. Is there a presenters mode? with the notes? I guess not. That's okay. So, sorry. So with this becomes a lot of implications. So with the possibility, some studies coming out saying as many as 1/3 of Americans are taking opioids each year. So what does this have to do with healthcare utilization? So pain is a commonly reported reason for postoperative readmissions, and surgical readmissions are associated with poor patient outcomes and increased resource utilization. So our objective was to examine the relationship between preoperative use and surgical readmissions, and our hypothesis was that those who used opioids preoperatively would have a higher incidence of unplanned readmissions. And then another objective was to examine the incidence of new persistent use of opioids following surgery. And our hypothesis was that persistent use would be common. So study design. So this was a retrospective cohort study using VA administrative data. And it took place in the VA hospital system between October 1st, 2007 and September 30th, 2014. And our population was a veteran population of general orthopedic and peripheral vascular surgeries with a total length of hospital stay between 2 and 30 days, and they had to be discharged to the community alive. So our exposure was the frequency of outpatient opioids used in the preoperative period. Primary outcome was the unplanned pain-related inpatient admissions in the 30 days following discharge. And again, some secondary outcomes you're interested in were all-cause unplanned inpatient readmissions and then post-operative outpatient usage. So to define frequency of opioid use, we subgrouped opioid users into 4 different groups using proportion of days covered in the 6 months period prior to surgery. So our first group was the no opioid group, which had no evidence of opioids prescription fills in the 6 months prior. Infrequent users who had less than 2 prescription fills in that 6 months. Frequent users who filled 3 or more prescriptions for opioids in that 6 months, and with less than 80% of proportion of days covered. And then our last group were our considered daily users with greater than or equal to 3 prescription fills and greater than 80% of proportion of days covered. So our findings, our study population, we started with almost 240,000 surgeries. We excluded those who were not discharged to community, and that was about 29,000 because we couldn't confirm that if they got their opioid medication or if it was filled at a long-term care facility. So we included a little over 200,000 surgeries. 18.4% of those were peripheral vascular. The majority were general surgery, 41.5%, and then orthopedic were 40%. Population demographics were that of a veteran population, so mean age about 64 years old, mostly male, and mostly Caucasian. So for our results of preoperative opioid users, going back to those subgroups, in the 6 months that we found that 63% of patients, so the majority, actually had no evidence of opioid use in that 6 month period. 17.8 were considered infrequent users. Frequent users, again with that greater than 3 prescription fills and less than 80% proportion of days covered, 7%, and then daily users, 12.2%. So some of the baseline characteristics by preoperative opioid use groups, most notably was the incidence of psychiatric conditions. So you can see those who were daily or any opioid users had an increase in psychiatric disorders from depression, anxiety, and bipolar. You can see it almost doubles from no opioids to daily users. So readmission by this preoperative opioid use group. So any unplanned readmissions overall, 9.2% of our cohort had any unplanned readmission. Pain-related accounted for 1.5% of the overall cohort. So looking again at these preoperative use groups, so For any unplanned readmission, 10.7% of those were frequent opioid users, followed by infrequent at 10%, and then daily, and then no opioids. And that's in contrast to pain-related readmission. You can see here it increases with the increase in opioid use. So daily was the highest at 2.4%, and then no opioids at 1.2%. So interestingly, we found variation by surgical specialty when looking at pain-related readmissions. So for general surgery, we found that daily users had increased odds of pain-related readmission than frequent and then infrequent. This wasn't as significant for orthopedic surgery. You can see there, nothing there was significant. And then also vascular was significant, where we had 1.5 for infrequent and then daily as well at 1.5 odds. So something we were also interested in was looking at that preoperative to postoperative transition from acute use to chronic use. There's a lot of speculation that surgeons are the gateway to opioids and opioid addiction. So we were curious about this for our veteran population. And we found, so preoperative is the top axis going down to post-op, and highlighted in red that 1.4% of our cohort went from no opioids to that daily group. And then moving a little farther, those who were infrequent, 2 or fewer fills to daily was 1.3. And here we have highlighted that a total of 22.2% increased in some capacity over the 6 months after surgery, but this also accounts for post-op pain medication, so it may have been 1 fill here or there. So conclusions, opioid use prior to surgery is common. Odds of pain-related readmissions were higher for those with exposure to opioids within the 6 months prior to surgery compared to the opioid naive group, and future work is needed to focus more on post-operative use. Thank you. Questions? Yes.
So on your odds ratio tree, which is very nice, by the way, it says adjusted both places, but you haven't mentioned what you're adjusting for.
Okay.
I would just put it on the previous slide, just models were adjusted for blah, 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 blah. You don't even have to go through it really much, just have it on there. Because if you say adjusted, people are going to go, well, what did you adjust for? And then you have to list it off the top of your head.
Okay. Thanks.
That was great. For the slide that looked at the table of pre and post-op, comparing the percentages towards the end, yes. So what about this 7.3%? Does this mean that only 7% that started on daily opiates end on daily opiates? And if so, isn't that a win? Shouldn't we be highlighting that?
Yeah, that's a great point.
Because I think I was expecting that to be a lot higher. Patient comes in on, scheduled Vicodin. What are the odds that in 30 days only 7% of those folks are on? And I guess it's daily, so it may not be scheduled, but I think that's something that I'm surprised at.
Well, so the way I understood you explain this, because this thing totals to 100, what it's saying is that 7.3% of the total population were daily on both of them. Not that it's only 7.3% of those that started daily stayed daily.
Correct.
So they couldn't
hard to
then.
understand.
Okay.
Okay, so then maybe it's, I see.
Okay.
So it could be category switching and we just don't know. Okay.
Well, I mean, it's more than half, right, who came in on, if you look at sort of the total, like the row totals, and then 7.5% over that row total.
Mm-hmm.
And I actually might, if you need time, I might drop this slide. I would keep it for the paper, but it's a little bit of a detour.
Okay.
It's very interesting, but it's a little detour from your main results.
So the other thing is you could turn it to call percentages, sorry.
No, go ahead.
Instead of the total sale percentages. So that way you would show which ones moved within the preoperative versions. So that would answer
That would
Ellen's
be
question,
helpful.
yeah.
Yeah.
But once I got oriented, then the bottom grid was a nice summary. I mean, so
Yes.
if you go to column percent, I think the challenge, I think Emily's comment might be, it's got good information, but to orient someone to the total thing being 100%, which then allows you to do that nice summation in the bottom, might confuse folks to misinterpret, wow, only 7.3% of daily users we're still using daily.
Yeah, correct.
If you go to column percent, then I don't know if you could do this the summary quite as well.
Probably not, but it would answer the question Ellen was wanting to know, which was how many people stayed daily, right? So, because if those people went up, right, got less, then you would be able to tell where did they get less.
Yeah.
But it wouldn't lead you to the bottom table
Of the overall summary statistic, which I thought was the most
It's just
valuable.
with limited time, it's just a hard one for people
Yeah.
to really wrap their head around. You're sitting there kind of trying to figure it out and work out the numbers, and then it's on to the next slide. So if you can distill it down in something that's faster to make the main points, I think maybe that would be helpful.
Okay, great.
Conceptually, can I ask a question?
Yeah.
So, in the first couple of slides, which I thought were good to sort of highlight the opioid problem, and then I don't know how somehow I caught that little blurb that said, surgery as the gateway to that one. Their surgery, something can be a gateway to opioid addiction. So in my mind, I was kind of prepped for sort of your post-op, you get started on opiates, and then you have a problem. So I was thinking post. So then you start talking about the pre-operative use of opiates, which I was struggling with the rationale.
Okay.
And then all of a sudden, then we did add the post on, and then I was trying to integrate that in my head. So I think I didn't get and maybe you said it and I just missed it, sort of why the focus on the pre-operative use of opiates and what the implication, even once you got to the conclusion, so what do I do with that information? Should we not be treating people for pain? Should we be alert to the fact that these people might require some kind of an intensive intervention because we anticipate they're going to come back? Like, I couldn't figure out what to do with the conclusions. What do I do about that?
Okay.
And I'm a doer, so I want to kind of know what it means. So conceptually, I think thinking about, I don't know what your thoughts about that are. What is the rationale for sort of focusing on the pre?
It's something that's not really studied, and surgeons are under a lot of scrutiny and they're being honed in on, oh, you're the reason for this.
Are they the ones doing the prescribing though? That wasn't, because I was thinking, no, the pre. Because the bulk of this is focused on the pre, which may not have anything to do with the surgeon, right? That could be coming from that.
And that's kind of the point, and that's something I do need to elaborate on and go and practice more in my intro. It's kind of, surgeons are kind of being blamed as these gatekeepers, but they're coming, 63%, or a large number already coming in on opioids. So they're not starting here.
Can you tell, do you have data to show where those prescriptions are coming from, since it's VA?
We didn't go into what specialty, but it would be interesting.
I think framing-wise, saying, okay, I think you have this slide, right? More than 1 in 3 Americans are prescribed opioids, right? So that's a big number. And then you say, okay, these people are coming in on opioids for their surgeries. Opioids are a mainstay of post-surgical management. What happens to these people? And I think that's an easier frame because, I sort of understand what you're saying with the blaming the surgeons and all that stuff, but that's like several steps that you don't necessarily have time for in the presentation.
Okay, yeah.
So I think just like 3 points for your background. Like, there's a lot of us, we use this as post-management. We don't know how that impacts, what happens post-management.
Yeah, great, thanks.
Do you have comorbidities? Are these people do they have chronic low back pain and that's why they are using opioids, or do they not even have a disease that would, necessarily be prescribed opioids?
Yeah, so we do have that, and I went through that really, really quickly. So history of chronic pain is on there. Is that something that I should highlight as well?
Yeah, I was looking at what you did highlight and I didn't even take it in and follow.
We do have comorbidities other than what's listed here as well. And one sort of thought when she shows the forest plot and it's broken down by orthopedic surgery and general surgery and vascular surgery, the orthopedic surgery, it's not as statistically significant, but one thing we thought is patients who have chronic joint pain, who then finally get their knee or hip replaced, then maybe are the ones who are better and are moving out of this daily opioid measure to hopefully feeling better.
That's really cool. Really good question.
Did your analyses adjust for depression and anxiety? Since it's so different.
I have a huge list of adjust for pain, closest pre-op, post-op pain, oral morphine equivalent, so the opioids that they were receiving. I don't know if that fell in or fell out of the model whenever we ran it. So I'll have to look into that.
Yeah, that was important.
For your first two slides, this might be, I love the idea of throwing a, hit them over the head that this is a problem.
Mm-hmm.
I personally got distracted by the number of high headlines. These two slides can help you with your intro. Can be bulleted points, like Emily was saying. It's a problem. It's also a problem in the post-operative period and the preoperative period. We don't know what the issues are, and then so as such, we wanted to do this study. That would help you kind of keep that intro. With that, you have the points on the slide to tell, and I mean you could slam with this later. I mean, I don't know what it would be like a
Or
close.
show it, right, and then the next slide has the bullet.
It has a bullet points.
Just one.
Yeah.
Or you pick one, it's just,
Like this is great in the news, and then the next one could be your scientific rationale.
it's all over the place here stuff.
Yeah. Okay.
Elise, how did you define or tease out pain-related readmission?
Yes.
Because surgery, we cause pain like all the time.
Yeah.
Yeah.
And
tease it out with the administrative data.
that's something that is on my list to ask Laura, because we've been trying to actually figure that out. I believe it's a VASCOIP definition.
So it's administrative codes, but this cohort is all VASCOIP nurse abstracted data, so it is retrospective data, but a human actually abstracted the data from the chart, and then we got it from VASCOIP.
But that is a great question that I do have plans on finding the concrete answer.
Something else, I mean, for future work or things like length of stay, I mean, in the VA, they're thinking about other implications beyond readmission. Could see where preoperative opioid use might lead to longer length of stay, more difficulty with pain management, other kind of indicators that hospital administrators and health systems focus on.
That's a great point. We need to do that in paper. We have that, like to say.
Okay.
Yeah, that's a great point.
Oh, I was just going to ask, was the 30-day, I'm guessing you looked at 30-day pain because it's expected that all those types of surgeries should have minimal post-operative pain at 30 days? I mean, is that why that 30-day cutoff was chosen as that?
We chose 30-day just overall.
So 30 days the readmission time frame, but we looked at opioid usage 6 months before and 6 months after.
Okay, gotcha. So the readmission was 30 day.
Which is sort of the standard surgical definition.
Okay, I was thinking
surgery-related readmission.
Okay.
Because I know for things like heart failure or MI, you may talk about longer time periods, but if you're going to have a problem from your surgery, it's probably going to appear within 30 days. And if your readmission is further out than that, it's probably your heart failure or your MI or something unrelated to your surgery.
Okay, the fact that it was pain-related readmissions made me think, they're looking at 30 days because pain-related shouldn't be an issue at 30 days, but I don't know if anybody else had trouble with that.
No, I think that's something that I need to put in my intro, highlight in my intro.
We will have to close here just to allow them to turn over, but any questions and follow-up, please.
Great feedback. Thanks.
I know this is hard. I know. He had a little statement from Miss Myron.
I don't know, but I remember that story. Like, we didn't have a meeting, and they were like, oh, sorry, you're done.
Yeah, right.
Yeah, no, I need to have time to
Oh, yeah. Well,